Good morning. Our first item for discussion this morning will be state hospitals. I'd like to welcome the director, Mr. Allenby, and his wonderful staff. And please proceed whenever you are ready. We do have a vote-only calendar that we will put over for a moment until we see we have the opportunity to also have a few other senators present. So if you would like to proceed with your presentation, thank you very much.
Thank you, Madam Chair. Cliff Allenby with the Department of State Hospitals. The analysis, I think, captures who we are very clearly and very well. If it pleases the committee, we could just move into the issues.
That would be fine.
Starting with the medical grade network, which is on page 7.
Yes.
I'm Jamie Mangrum, the department's Chief Information Officer. We're asking for $7.4 million in 2014-15 and $2.3 million in 2015-16 with 2 PYs. The hospitals are planning on moving forward with telemedicine, telepsychiatry, and electronic health record technologies to provide the same level of access to the paper-based patient record that we have today. It's necessary for us to put this infrastructure in place so the clinicians can gain access to the electronic form of the patient record.
Thank you very much. Are there any comments by Department of Finance or the Legislative Analyst's Office? And I do know that there doesn't seem to be any objection to this item. We will take a vote on that in a little while when we have a few other senators. Do you have any other things you'd like to add?
No, ma'am.
To that? Okay, very good. Then we'll go on to the next item, which is the statewide enhanced treatment units and capital outlay.
I have to my left our medical director, Dr. Kate Warburton, who is a forensic psychiatrist who can talk to you about why we believe we need an ETU.
Thank you very much. Welcome, Doctor.
Thank you. I don't think it's any secret to you or anyone in this room that the state hospitals have a major issue with violence in our facilities. Our research and information gathering, which includes reading the literature and talking to people from other states, seems to indicate that this is a national trend. If you look at media reports from state hospitals in other states, people are starting to report an increase in violence. We have several hypotheses about why this is happening if you're interested. The bottom line is I think that as the largest forensic system in the country by almost a factor of 3, we are experiencing this in a much more acute and severe way than anyone else in the country, and it's time for us to be innovative. We need to have safe treatment environments for some of the patients that we now serve who are different than the patients we used to serve. And in order to do that, we need some physical plant infrastructure to aid in this new treatment model.
I think it's important to point out that this is not, if and when we are able to get these new treatment units, I think it's clear that the decisions that have to be made for those placements will not be arbitrary. We do have clients' rights folks in our facilities. They will participate in the decisions on a clinical basis as to whether that's an appropriate action to take. One of the questions was raised in the staff analysis was how does this relate different from the ETUs we now have at Atascadero and Coalinga, and I'll let Dr. Warburton kind of explain the differences we think we have.
When I saw that question, I kind of thought of an analogy of heart disease. We're starting to conceptualize violence as treating violence as one of our primary missions in the state hospital system. And like heart disease, violence can have many etiologies. It can be a very complex picture of why someone's heart's not working or why someone's violent. If you look at all of the standardized and reliable violence risk assessments, they delineate many different types of risk factors that can cause someone to be violent. So we do have 2 pilot projects running in the state where we selected individuals to treat that we knew that we could treat safely. And I would say to that end, it has been successful. But there are other individuals who do not meet the entrance criteria for those specialty units because they're too dangerous. And we couldn't put all of them together safely. And those are the people that we're trying to serve with enhanced treatment programming.
Perhaps you could be a little more specific. The question actually was a bit more specific. We were asking if you can describe how the current ETUs operate and whether or not they are an effective treatment model. So perhaps you could tell us with a little more specifics how the system's working now.
The enhanced treatment unit at Atascadero, there's a distinction in psychiatry between Axis 1 and Axis 2 disorders, although that distinction has been changed in the latest iteration of our DSM-5. However, in general, that was the methodology we were using at that time. Axis 1 disorders are, for lack of a better term, more traditional affective or psychotic disorders that our science and our armory of treatments understands very well. So, for example, if someone is psychotic, they tend to telegraph when they're about to be violent pretty clearly. Threat control override symptoms are generally the symptoms that cause psychotic patients to be violent, and you can tell both from what they report, how they act, looking at them, if they're experiencing those symptoms. So we have ways of effectively intervening, therapeutically intervening with Axis 1 diagnoses. So that unit selects for those people. The behaviors have to be driven by that type of symptomatology. And another entrance criteria for that unit is that they can be treated, those symptoms can be treated in fairly short order, so that we can try to successfully take that group of people out of the mix and treat them successfully. One risk factor that we do not want to have in that patient population is a risk factor called psychopathy. Psychopathy is more of a character structure. I think Dr. Robert Hare, who's the leading scholar in the field of psychopathy, the title of his book is Without Conscience. It's a different mindset. It's a different character structure. And those individuals tend to commit more organized or predatory or instrumental planned aggression. And we can't sort of mix those two groups together because the latter tends to prey upon the former. So by virtue of selecting for people who are yes, they're very violent, but they have a type of violence that we can safely manage even when we put them all in one place, we can be successful to some extent. And the question is, are they successful? I would say it depends on how you define success. Are people still being hurt? Yes. Are we objectively reducing aggression based on looking at data? Yes. So somewhat successful for a certain subset of the population that we've identified we can safely treat in that type of environment. The SSU at Coalinga State Hospital selects in their entrance criteria for more of the latter group, more of the people who are characterologically predisposed to organize or plan their violence, which is a much harder thing to prevent in the type of hospital setting that we have today with wide open dormitory-style units. I would say that at Coalinga, we have mostly sexually violent predators. I think 70% of the population at Coalinga are pedophiles. So we can put people who organize their aggression all in one unit because their victim pool doesn't exist on that unit. There aren't young children at Coalinga for them to prey upon. If we put people who had the character structure, the criminogenic thinking and behavior of some of the individuals on that unit, who also had the level of severe physical aggression that we see with the ETU unit, that would be unsustainable in any type of current physical plant infrastructure that we have. It would be, we would like to do that successfully, but it would be a very dangerous, ill-advised thing to do.
All right. So the way the physical system is right now doesn't allow you the individualized treatment? Would that be your main?
It doesn't allow us to treat people who have certain types of violence, like organized violence, at a severe level, if that makes any sense.
Yes. And then also, the other question was, if there were to be locked rooms, how would the administration ensure that they would only be used for treatment and not for punishment?
There is an entire science called violence risk assessment. There's an enormous literature about the science of violence risk assessment. We would base any admission into the enhanced treatment program on evidence-based scientific violence risk assessments done by trained clinicians. So it would be a clinical decision based on whether someone posed an unacceptably high risk of severe aggression in the regular inpatient environment. And we have done a tremendous amount of planning. We've brought in thought leaders, some of the most well-respected psychiatrists in the world to come help us develop thinking around guidelines for admission and treatment in this enhanced treatment program. This isn't about punishment. This is about safely treating people. We can't treat anyone if our units are in chaos.
Right, but you would have a system in place.
Absolutely.
So that this placement would be based on treatment of individuals.
Absolutely.
All right.
Evidence-based clinical decision-making.
Okay, very good. All right. Do you have anything else you'd like to present under that
No, thank
section?
you.
Okay, all right. Members, do you have any questions on this item? In the meantime, Legislative Analyst's Office.
Thank you, Madam Chair. Sarah Larson with the LAO. Just to kind of be specific, this proposal is $1.5 million general fund to allow DSH to contract with DGS for the analysis and design of 40 enhanced treatment units, roughly. We have a couple of concerns with this proposal, and we would recommend that the legislature reject this proposal as it currently stands. Under current licensure by the Department of Public Health, DSH doesn't actually have the authority to operate locked enhanced treatment units. And this proposal doesn't include language that would provide the department with that authority. Unlike the proposal that we'll hear on the patient management unit, where there's a relatively simple statutory change, this proposal requires more complex policy decision-making. So, for example, there's no clarity currently about whether these locked units would be at all hospitals, at specific hospitals, whether they would require individual bathrooms, what size the rooms would be, et cetera. And without those details, our office is unclear how DGS would be able to provide an analysis like the one that's suggested in this proposal. So while we recognize that there's, an enhanced need for these enhanced treatment spaces, we think this proposal is premature and would recommend that the legislature reject it.
Okay, thank you very much. Department of Finance?
Carlos Ochoa, Department of Finance. I would like to say that the study is underway, and we anticipate getting the results of that study in the next 2 to 3 weeks, and have a May revise item to update the status of that and the proposal at hand. So, we would like to notice the recommendation of holding the item open.
Okay, thank you very much. Members, any comments? Public comment on this item? And if there are any public comments on the earlier item, medical grade network, those would be appropriate to be made as well, since we didn't have public comment earlier. Good afternoon.
Good afternoon. Margaret Johnson with Disability Rights California. We have significant concerns with the proposal around the enhanced treatment units. In general, we don't have a problem with the state hospitals developing enhanced treatment units or developing models that work for different populations that are in the hospital, but we have some significant concerns with this particular budget request because it seems premature and troubling in many ways. And I'm just going to mention a couple of things that we're concerned about today. First of all, we're troubled by the desire to ask for funding to create rooms to lock patients into, because the existing programs that are already at Atascadero and Coalinga are unlocked units. So people from about 12 to 20 patients are in these units, so they don't mingle with the rest of the population. Further, Department of State Hospital can already expand these kinds of programs or similar programs. What this proposal is asking for is that they create rooms that lock so that people are locked into them. And as pointed out by the LAO, current licensing requirements wouldn't allow them to do this without making some changes in the law. In addition, we're troubled by the lack of due process for people to get into the units. The due process is generally limited to the treatment teams, and they're looking at, whether people should go in there or not, and they rely on the writ process as a way for people to appeal any decisions. We think that there should be a more heightened level of due process if these things are going to go forward before people are placed in them. So those are our, kind of initial concerns, and we would urge you to reject this budget request as premature and not necessary.
Okay,
Thank you.
Thank you very much. Good morning.
Good morning. Kirsten Barlow on behalf of the California Mental Health Directors Association. We also have some concerns about the proposal. I think most of what I would talk about, though, is framed around AB 1340, the two-year bill that's mentioned in the staff analysis of the issue, since it seems to be a very substantially similar proposal in terms of creating ETUs in the state hospital system for violent or aggressive patients. So we had communicated to that author's office some of the concerns that we had, and so I wanted to share with you those, since they probably would be echoed in the case of the department's proposal here this year. One of the things that we wanted to specifically mention is what would really be the cost to counties, since we would be purchasing services for civilly committed individuals who are in the state hospitals. So how would those costs for these ETUs be passed down to counties to the extent one of the individuals we had placed in the hospital were placed in the ETUs? Also, similar to some of the concerns that were mentioned by Disability Rights California, we need to be very mindful of what the implications for patient care and civil rights would be. We don't have enough information, I think, at this point to know about the kinds of clinical interventions that would be provided to the individuals beyond really containing them because of their troubling behavior. And would want to make sure that there are some ways to ensure that people are placed back into the least restrictive type of setting as soon as possible. And then the other piece is really the lack of reliable tools that exist and research for predicting violence. And we've seen that in the media, and there's a lot of debate around that around the country. Anytime there's an act of violence by someone who may or may not have had a mental illness, there's really a lot of controversy in the field about whether you can accurately predict violence. So we do have some concerns about what the criteria would be used to assess whether an individual was the right fit or not for one of these ETUs. So at this point, just wanted to share the concerns that we have with the proposal. Thank you.
Thank you very much.
Madam Chair and members, Jacoby Pizzati with Merch Bassoff and Associates. We represent the California Association of Psychiatric Technicians. We're also a member of the Safety Now Coalition, which is consistent of CSLEA, CAPT, ASME 2620, SEIU Local 1000, and UAPD. We are the Safety Now Coalition is the sponsor of AB 1340. And we have come together in stakeholder meetings to produce a bill that we think addresses all the questions that the analysis has raised. And on top of that, we included the disability rights groups as well in the drafting of the language of AB 1340. So we wanted to make sure that all their concerns were met. I still believe that they will fundamentally not ever agree to some of the provisions in the bill, but we are doing our best to make sure that we can handle a certain type of patient and provide the proper treatment and use the least restrictive method of providing that treatment. One of the issues that we've had with some of the patients that when they become aggressive is when you are forced to use seclusion and restraint on somebody, you're often putting someone in a 5-point restraint and tying them to a bed for a period of time with one-to-one or 2-to-1 supervision. It's almost impossible to provide any sort of treatment while doing that. If you have an individual that you can put in a externally locked room where you can actually talk to them, you can talk them down and get them to de-escalate, then that is a better way of providing treatment. So with that, we support this provision.
Thank you very much. Next speaker.
Hello, Madam Chair and members. I'm Zach Hatton. I'm a recreation therapist and chief steward for ASME Local 2620 at Napa State Hospital. So I do work at the hospital, and we do see violence on a daily basis. And Kobe is correct that we can't treat every patient on a unit if we have one patient that is creating most of the problems, most of the violence for us. So being able to remove that individual and provide treatment to them on an individual basis on a unit, we can still provide that through a locked door, open the door when we want to, when they're able to come out and actually participate in more of a group setting. So if you look at it in the big picture is that all the patients at the hospitals will get better treatment, more effective treatment, if we're able to remove pieces of that. And like Dr. Warburton said, this is a unique, great thing that we need to move towards as violence increases in our hospitals and our patients are being assaulted and staff are being assaulted. This is the way that I think is going to work best for us to be able to treat everybody effectively. So with that, ASME 2620 supports this. Thank you.
Thank you very much.
Hi, good morning. Doug Chiappetta on behalf of the Union of American Physicians and Dentists, also with AFSCME. So this is an AFSCME-sponsored bill. We represent the physicians who are at the state hospitals. As I'm sure you've heard, there was a murder a few years ago with the psych techs. Some of our staff have testified here, with abrasions. It's a very difficult, entrenched environment, very forensic population. We understand there are some particular concerns with the bill. We recognize that in terms of the working out the fine points, but the assessment that it's premature, I mean, we've been dealing with this in the aftermath of the death of Donna Gross for 2-3 years now, and the physicians and the staff and the patients need some adjustment to the environment. So we hope you'll look at that in a favorable clinical outcome. Thank you.
Thank you very much.
Selena Pryor-Dansby with SEIU Local 1000. I would just like to echo the comments of my brothers that went before me and ask that you would give serious consideration to this proposal as we have the nurses, or we represent the nurses who are on the ground every day.
Thank you very much.
Madam Chair and members, Randall Hager for the California Psychiatric Association, especially those psychiatrists in our state facilities. We support this proposal, and we, with respect, would reject the notion that it's premature. There is still time to work out details. If 1340 is not sufficient in its scope to allow the protections that people seem to want, then there is still time to do that. We would urge you to keep this item open and have all parties work on maybe some of those extra details, some procedural descriptions, and statutory language. So on behalf of psychiatrists, that's what we would recommend. Thank you.
Thank you very much. All right, members. Senator Martin.
I just want to acknowledge, I think the recommendation is that we are going to keep this open. It seems like there's been a lot of engagement of people both working with a primary concern of staff safety as well as patient safety. And the challenge is to strike that balance, and I think we've heard the importance of due process and protection for patients' rights. So striking that balance is the challenge. It sounds like AB 1340 is a vehicle legislatively where some of that conversation continues to happen. So I will remain interested to see the progress of those discussions in finding that right balance. But I think we have to be very mindful that it's a crisis circumstance that exists today and will continue to exist in every facility where there's the prospect of violence. And so our ability to move forward, I think, is critical for all of the interests stated for patient rights protection, staff protection, and patient safety. So appreciate the work that the stakeholders are doing, and look forward to that continuing. Thank you.
Thank you very much, Senator Monning. And I would agree with you. We, of course, want to make sure we have the very best treatment for our patients. And obviously, we also want to make sure that it's in a very safe environment for those that are caring for them. So the recommendation is to keep this item open.
Thank you.
And without objection, we will keep the item open. All right. Thank you very much. No. Let's establish a quorum while we have one. We have, yes, go ahead.
Madam Chair,
I'm here.
Senator Monning.
Here.
Senator Walters.
And members, we're going to go back just for a moment. We did have some vote-only items, and let's run through those very quickly. And we're going to take them each one at a time so members can voice their interest. So the first item was the third-party billing BCP. Members in support are, I am in support.
Aye.
Aye. Aye. Aye. All right. That passes on a 3-0 vote. Okay. The Cal OSHA Standards BCP. Members, what is your interest?
So moved.
Moved by Senator Monings. Members?
Aye.
Aye by Senator Monning, no by Senator Walters, so that's a 2-0 vote. Excuse me. 2-1. My apologies. I'll get the hang of this eventually. The next item is the seismic upgrades at Atascadero. Members, what's your pleasure? So moved by Senator Monning. Members?
Aye.
Aye. 3 ayes. Item 4, the security fencing at Napa. Members? So moved by Senator Monning.
Aye.
Aye by Senator Monning. Aye by Senator Walters. Aye by Senator Corbett. 3 ayes. Then the fire alarm upgrade at Metropolitan. So moved by Senator Monning. Senator Monning.
Aye.
Senator Walters.
Aye.
3 ayes on that item as well. Okay, members. Yes, members, and also we're going to return to the medical grade network, which we heard at the first part of the hearing. Was there any public comment on that? I just want to make sure since we didn't call it at the time. Okay, very good. Motions in order on the medical grade network.
So moved.
Moved by Senator Monning. Senator Monning?
Aye.
Are you in support? Senator Walters? That's 3 ayes as well. All right. If you follow the bouncing ball, we are now on to item number 3, the patient management unit. Welcome.
Good morning, members. Mark Beckley, Department of State Hospitals, Deputy Director for Administration. The first question on the patient management proposal is how many vacant beds does DSH have throughout its hospital system and where are they located? Currently, DSH has 220 vacant beds. The majority of these are specialized beds, meaning that they're beds reserved for either patients with special medical needs, beds reserved for people of specific populations such as Coleman patients or sexually violent predators. So in fact, we only have about maybe 32 beds that could be used for general population needs. And we are in the process of filling these beds. Those beds are predominantly based at Atascadero. We do have a plan to fill all of these Atascadero beds by the end of the year. And then we think that we'll have pretty much a full census in our hospitals. And this kind of works into the next item, which is the IST wait list. We think that once we have our beds filled at Atascadero, we'll definitely have a need for the additional beds that we're requesting at Coalinga to further reduce the wait list of our IST population. Then I think, if you like, I can move on to the next question.
I just like a little more explanation about the wait list. Why do we have a wait list if we do have some vacant beds?
Yes.
Help me understand that.
What the situation we have, particularly in our Atascadero State Hospital, is we're having difficulties recruiting psychiatrists, and so that means that we can't utilize all of the units that we have right now. We have been successful in recent weeks in recruiting psychiatrists at Atascadero, so that will help us work down our wait list. But again, we're limited in terms of the types of beds that we can use. So, like I said, we have about 32 general population beds that we're in process of filling right now with psychiatrists that we've recently hired. The other vacant beds are in specialized units. So we have a unit dedicated to, say, medical needs. So we have patients on those units that are receiving medical treatment, primary care, recovery treatment, and we also operate SNFs, skilled nursing facilities. So really the way that those units are designed, they can only be used for those specific populations. It would be inappropriate to try to put some general population individual on that unit because we don't have the right treatment to treat those patients on those units. Then we also have units that are dedicated to specialized populations such as sexually violent predators. It wouldn't be appropriate to put an IST individual on a unit with a sexually violent predator, so we keep those populations separated. There's also a certain number of beds in our system that are dedicated to Coleman class patients, and that's by court decree that we have a certain number of Coleman beds within our system at any given time, so we can't just place a general population person into a Coleman bed. So those are the reasons why we have these specialized beds and why we currently have some vacant beds within our system. The overall vacancy rate is about 4% in terms of overall vacant beds. And then for general pop beds, it's like less than 1% right now. And we believe that it is healthy in our system to have a certain level of vacant beds in our system at any given time, just to create fluidity within our system. We can never get out of the wait list issue unless we have beds available to admit patients and to house patients timely.
All right. And there are a few other questions that we asked you to answer.
Yes. The next one asks, how will DSH ensure that the new system will allow for judicial discretion when appropriate? So with our patient management unit proposal, what we're proposing is to have certain criteria by which we'd screen patients for appropriate placement within our system. We would do, as Dr. Warburton had previously mentioned, a violence risk assessment, so an individual's propensity for violence. So if we have a highly violent patient, we may not want to house them in an open campus setting such as Napa. We might want to put them in a more secure facility like Atascadero. Another criteria that we would use is medical needs. So if we have somebody with acute medical needs, currently we operate 2 SNFs in our system, one at Metro and one at Napa. So we want to make sure that those patients are placed in a place where they can receive appropriate medical care. We also have sometimes patients with specialized needs, such as hearing impaired individuals or visually impaired. So we would want to place them in a hospital that would allow to treat them in that way. We would never, I mean, obviously, the judiciary branch, they can exercise discretion when they feel it's necessary. So if, a judge felt a strong, compelling need to place a patient at Napa, we would want to engage in a conversation with that judge, kind of listen to their concerns, relay our concerns as well. So I think there's always going to be an opportunity for dialogue in any placement arrangement. But we have spoken with your staff and the assembly staff about developing language where the criteria would be clearly spelled out, referral process. Our bias is always going to be towards placing the patients within their communities. We would only look at a hospital outside of the community if there's a specialized need that needed to be accommodated, or we'd also have to balance the needs of the patient. So if there's no beds available at Napa, and you have a patient who's on a wait list who's been in Napa County Jail for, say, 30, 60 days, is it in the best interest to have that individual in a jail not being treated or being placed timely? So there has to be that balance. So we would also consider that as part of the criteria that we develop. But again, we're happy to work with your staff on language to further develop the process and the criteria.
And as you develop that criteria, what will be the process to develop that criteria, to ensure that you're placing patients as close to the communities as possible when you can? What will be the process?
I think what we have in mind is at DSH Sacramento, we're going to do this initial screening, and again, they'll have clear instructions to place the patient within their communities as a primary condition. If there's a compelling reason to place them outside of their communities, we'll probably have some sort of process by which a rationale is given, and would record that. But again, I'm sure there's something we could put in language, such as trailer bill, that talks about that hospitals should always, place patients when they're within their communities when appropriate, and we could even report back in terms of our, when we do and when we don't, the reasons why we don't.
All right. Thank you very much. Members, any comments? Yeah. Okay. Legislative analysts?
Thank you, Madam Chair. Sarah Larson with the LAO. We would recommend that the legislature approve this bill, but only along with associated trailer bill language. So generally, we think the proposal is a good idea. It allows DSH to place patients more quickly, reduce lengths of stay, and potentially reduce costs associated with treatment. However, we would point out that the department currently lacks the authority to fully implement a patient management program. So under current statute, judges are allowed to commit patients to a specific hospital or to the state hospital system. And unless that's changed, the department wouldn't be able to take full advantage of this system. Judges would still be able to commit patients to specific locations, so the benefits of the program, such as specialized treatment and reducing costs, would not materialize. So because of that, we would recommend that the legislature approve the proposal along with trailer bill language clarifying that commitment to the state hospitals constitutes commitment to the state hospital system rather than to a specific hospital. So if you have any questions about that, we'd be happy to answer them.